Today we'll be discussing the case of Tim Heidler. It's June 1978. Tim is on his way to a very important class on his motorcycle. He was training to become a firefighter, and so to get to this class, he decided to take a route on an old logging trail. This was a very normal day for him, but as Tim rode on that trail simply trying to get to his class, suddenly everything went blank. Tim had gotten into a very bad accident, one that technically wasn't even really an accident, but rather a horrific incident caused by the intentional actions of another person. This incident severely damaged his neck, and after emergency surgery, Tim's voice box was damaged so badly, there was nothing they could do to save it. For 20 years following this, he was forced to live without a voice. But it was very soon after discovering the possibility of getting the world's first voice box transplant from a human donor when Tim immediately jumped at the opportunity. This rare procedure would go down as a very complex feat, and after seeing what happened to Tim, several debates would go on as people argued whether this procedure was ethical or if it was inhumane. But before we get into this case, just to introduce myself, my name is Petal Palmer, and on this channel I post anything medical, mysteries, and crime. If that is something that sounds interesting to you, please consider subscribing if you end up liking this video. Alright, let's get into this case. Timothy A. Heidler was born on Saturday, June 1st, 1957 in Hollidaysburg, Pennsylvania. This is a small town in central Pennsylvania, home to a population of about 5,500 people. It's located on Juniata River, and it's highlighted by beautiful parks. He had 2 brothers and 4 sisters, and Tim has always been interested in the outdoors, so living here was great for that. He enjoyed camping, fishing, country music, and sitting by campfires. And he even enjoyed cooking, whether inside or outside. At 20 years old, Tim worked in construction, but he was training to become a firefighter. So he had been training, going to classes, and doing what he needed to do to get that done. He had a motorcycle, which he would use to get around. And the day after he turned 21, on Friday, June 2nd, 1978, he had a fire training class or seminar that he was going to be attending. So as he usually did, he hopped onto his motorcycle to head to that class. Tim was driving on an old logging trail nearby in Altoona, Pennsylvania to get to this class, and he was going at just about 40 miles an hour. Nothing would have raised alarms about this ride, but that quickly changed because as Tim rode on the bike on that logging trail, he had ridden directly into a steel cable placed between 2 trees. When Tim rode into this cable, it got him right in the neck, and not only did it split his neck open, but his esophagus or food pipe got severed. He suffered some serious internal bleeding, and both his larynx or voice box and pharynx, which is your throat, got crushed. Tim was rushed to hospital in critical condition, and the medical team wasn't sure if he'd be able to make it. But after 8.5 hours of surgeons operating on him, they finally were able to get him to a stable condition. They described that Tim barely survived. In fact, Dr. Douglas Hicks, a speech pathologist at the Cleveland Clinic's Voice Center who would eventually begin treating Tim, described that he was, quote, lucky to be alive. Despite him surviving through this, though, there was one major thing that resulted from this incident. Because Tim's larynx or voice box was damaged so badly, surgeons were left no choice but to leave a hole or opening in his neck. This hole is called a tracheostomy or a stoma. The pathway for someone breathing is for the air to go through their nose or mouth, down to their throat, which is their pharynx, then their larynx, then their trachea, which is your windpipe, and then your lungs. Tim's larynx and throat were crushed. So the reason they had to leave a stoma or hole in his neck is because since your larynx is directly connected above your trachea or windpipe, the only way you could get air down to your trachea than your lungs when breathing through your nose or mouth is if it ends up passing through the larynx first. But because of how badly his larynx was crushed, this connection was not possible anymore. So the stoma stoma was created and a breathing tube was placed in order to create a pathway to the trachea so he'd be able to breathe. This is a procedure often done in patients with laryngeal cancer who receive a laryngectomy to get their larynx removed, thus requiring a stoma to breathe, as seen in the case of Terry Hall, for example. Although he was able to breathe, with them removing his larynx, aka his voice box, Tim was no longer able to speak, leaving him what's called aphonic. As Tim remained in the hospital just trying to recover, he was faced with various health struggles that were harmful to his life. He not only developed hepatitis, but he also developed a life-threatening staph infection. So bad, it almost required him to have his legs amputated. Tim did a total of 27 operations, remaining in the hospital for 2 whole years before he was released. But things still were not easy. Just 1 year after the injury, he lost both his sense of taste and sense of smell. And in addition to not being able to talk, Tim developed osteoarthritis in his knees. So with all of this, he was unable to continue with pursuing his dream of becoming a firefighter and just truly working in general. 2 months after the incident, in order to communicate, Tim was given an electric voice box or an electrolarynx to try producing speech. Specifically, he was given a Cooper-Rand electrolarynx. An electrolarynx is, quote, a vibrating device which is placed on the neck to transmit vibrations into the pharyngeal column of air.
Basically, it makes a tone, like pushing the button, and coordination again, and using your lips and your tongue, you make these syllables.
So this is an external device which relies on vibrations to produce sound from somebody who's aphonic, which on one hand is good because it allows somebody to communicate. But the drawback with that is that it produces a voice that is very artificial or robotic sounding. And it's not only something that the person has to get physically used to in order to create the correct sound, but it's also something the people listening to them need to get used to as well. Tim stated in a May 2nd, 1999 New York Times article, quote, people were trying to figure out how you're talking and we're not paying attention to what you are saying. It has that robotic voice to it, and you almost have to watch the person's lips to understand. With him further describing that whenever he was on the phone, quote, people just think they are talking to a computer and they just don't pay any attention. Tim described the struggles faced with having this be the voice he used to communicate with people, even describing mistreatment and ridicule he faced while trying to communicate with others.
Imagine trying to call Domino's and order a pizza. Imagine pulling up to a drive-up window and ordering a hamburger. It doesn't work. People laugh at you.
And he expressed how difficult it is to lose your voice and not be able to talk to others normally.
Not being able to talk, I think, is terrible. Next to being blind, not being able to see, but not being able to talk and communicate is very hard for anybody.
Further describing the struggles, saying, quote, communication is the main goal in everything. Without communication, nothing works. That's why a lot of people who've had laryngectomies stay at home. They don't go out. They just sit at home and ferment to nothing. They're depressed. For nearly 20 years, Tim ended up living exactly like that. He'd gone to various different institutions, seen so many different doctors to try to treat his injury, to see if it could possibly be fixed. One institution even attempted to reconstruct his larynx, but not only was his larynx narrowed, but it was also shortened, and there was a bunch of other structural issues, so these attempts didn't work out. Not just this, but a barium swallow test showed that not only was his larynx narrowed, but both his throat and esophagus were narrowed, and he had a pharyngolaryngeal fistula, meaning he had an abnormal connection between the mucus lining of his throat and his larynx. And this resulted in fluids secreted from his mouth and throat to leak and cover the area just above his vocal cords. But while it seemed like this would have to be what he would would live with for the rest of his life, it was finally in 1996, when he was about 39 years old, when he had heard about some news that changed everything. One day, Tim came across a news report and immediately it caught his attention. This report was about a young girl who had received a trachea transplant, or a windpipe transplant. Both Tim and his friend, who was a nurse, saw this report, and upon seeing it, his friend was like, oh my gosh, like, what if you got something like that done for yourself? They did some research into laryngeal transplants to see if that was a thing, and eventually they came across a news story from a man named Dr. Marshall Strome, a surgical specialist who was on the lookout for a suitable candidate to receive the world's first larynx transplant. Dr. Marshall Strome is an otolaryngologist who at the time was at the Cleveland Clinic Foundation. He studied at the University of Michigan all through undergrad, medical school, and residency. While training to become a licensed physician, he also served in the United States Army from 1965 to 1971 as lieutenant to captain. And it was finally in 1970 when he finished his residency and training, becoming board certified in otolaryngology. Now, during that final year of his residency in 1969, something very interesting happened, because it was during that year when the actual world's first larynx transplant technically happened. It was in the 1960s when the concept of laryngeal transplantation was first introduced by doctors Work, Bowles, Ogura, Takanachi, and Silver. In October 1965, Dr. Work and Bowles published an article about larynx replantation in dogs. And for all the other mentioned doctors and their teams, in 1966 and 67, they published studies regarding their experiments conducted on dogs to try developing the procedure. It was then finally on Monday, February 10th, 1969, in Ghent, Belgium, when a 62-year-old man was the first person to receive a larynx transplant, performed by a physician named Dr. P. Cloyskens. This man received a total laryngectomy after being diagnosed with laryngeal cancer. A laryngectomy is a procedure where one's larynx is partially or fully, aka totally, removed. So after having this happen, Dr. Cloyskens replaced his larynx through the transplantation. What was different with this one compared to the one we'll be discussing with Dr. Strome was that this first transplant was non-vascularized, meaning the donor larynx was harvested without retaining its original blood supply. Thus, it relied on the blood vessels of the recipient in order to revascularize and integrate. What we'll see happen in the future with this case and others is that this in fact would change to become vascularized, which for this transplant is preferred for better viability. After this procedure, the man was able to speak and he no longer required the stoma. For the first few months, he was doing relatively fine with his new larynx, but it was 8 months after the transplant when the cancer had come back and he passed away. Dr. Strome was just finishing up his residency in 1970 when this all happened. From 1969 to 1971, he served as an assistant professor of surgery at the University of Connecticut. Following this, he moved to Boston, Massachusetts. And it was from 1971 to 1993 where, in addition to working as a surgeon at various hospitals, he served as an assistant professor, assistant clinical professor, and then an associate professor of otolaryngology at the Harvard Medical School's Beth Israel Hospital. It was after his time at Harvard when, in 1993, he moved to Cleveland, Ohio, becoming the emeritus chairman for the Head and Neck Institute at the Cleveland Clinic. This was in addition to being a professor there and also being a professor at Ohio State University's Cleveland Clinic Foundation Health Sciences Center starting that following year. It was in both Boston and in Cleveland where he did extensive research crafting the larynx transplant. For almost 2 decades since the first procedure in Belgium, nobody performed another larynx transplant. But it was in 1987 when Dr. Strome truly began working to create the procedure, marking the scientific age of larynx transplants. He began a systematic research program in which he experimented on rats to try to develop a vascularized larynx transplant. He studied the operation, focusing on 4 major aspects: revascularization, reinnervation, rejection, and ethical concerns, with the main goals being to successfully complete the procedure in which the patient is able to breathe without their stoma, they can swallow properly, and they can produce sound. It was after almost a decade of research and practicing when Dr. Strome was finally at a point where he felt ready to get this performed. It was just a matter of finding a candidate who truly qualified for this operation, something Dr. Strome felt like they would never find. Tim thought that this procedure would be a great opportunity for him. So once he came across the news report of Dr. Strome, he immediately signed up to possibly get this done. Tim met Dr. Strome at the Cleveland Clinic, and they were able to discuss it some more. Allotransplantation refers to, quote, a procedure in which a genetically different organ or allograft of the same species is harvested from a deceased or live donor and transferred to the recipients. Allo means other, so when you say allotransplant, it refers to the organ being transplanted to another human who is not themselves. A vascularized larynx transplant specifically would refer to what's called a vascularized composite tissue allograft, also known as a VCA. These are, quote, operations performed to heal patients with composite tissue loss that impairs body integrity and causes dysfunction, thus improving their life quality. This would include transplants of structures such as the face, limbs, long bones, and soft tissues. These structures were initially classified as tissues, but as of July 3rd, 2014, VCAs have been recognized and formally classified as organs by the United States Department of Health and Human Services. Meaning, your face, for example, is now considered an organ. And for our current topic, the larynx is now considered an organ as well. But at the time of this case in 1998, it was not. It was classified as a tissue. Doing a laryngeal transplantation would be a very complex procedure. It would involve a short absence of blood circulation, blood vessels and nerves having to be reconnected, immunosuppressive therapies, and possibility of rejection by the recipient. In general, allotransplantations are still one of the most controversial topics in modern medicine, despite the rapid development of them. Allotransplants like the heart, kidney, and liver have been done for a bit longer, so by now they are more developed, but regarding organs like the face, arms, and hands, these are still quite new. A vascularized larynx transplant hadn't been done before, so it was going to be quite the feat. But before even thinking about getting it done, they had to make sure Tim's physical condition was at an acceptable level. Tim, who was 40 years old at the time and unemployed, was overall healthy. He did experience hypertension or high blood pressure, but it was mild. It wasn't caused by any other medical conditions, and it was treated just fine with 2 medications. He did have mild dysphagia or difficulty swallowing, but regardless of this, he still ate a normal and healthy amount. He didn't smoke, he tested negative for cytomegalovirus, Epstein-Barr virus, his serum creatinine concentration was normal, and disregarding the stoma and the abnormalities he had with his larynx, throat, and trachea, his physical examination was normal. With the physical being all good, the next important thing they needed to do was a psychiatric, surgical, and speech pathology evaluation. They had Tim interviewed once by a psychiatrist and 4 times by members of the surgical team and a speech pathologist, and they did this in order to understand and evaluate if he truly wanted to do this. During these interviews, they extensively discussed indications, risks, benefits, and ethical concerns. They asked him why he wanted to do it. They let him know that he could possibly lose his life from getting this done.
I also told him that if you look at the history of transplantation where immunosuppression had been used, no organ had really survived long term. And why should I think that this one would potentially be different?
Dr. Strome, of course, hoped that this case would be different, considering all the years they put towards researching this, and that this procedure could last for a while. But obviously, with any kind of procedure like this, especially the first, there was no way to guarantee or even estimate what the outcome would be. Nonetheless, Tim was certain this was what he wanted to do. And everybody who interviewed him agreed that Tim understood the risks that came with the procedure and that he had the appropriate motivation towards getting it done to restore laryngeal function. It was after this when the team brought this case over to the Institutional Review Board of the Cleveland Clinic Foundation, who too approved of it. Finally, all they needed was written informed consent, and Tim indeed signed off for this to happen. All it was a matter of now was waiting for the moment a donor became available. From July 1997, they waited to see if they would get a donor larynx, but time and time would go by and they couldn't find any. Dr. Strome passed up on a lot of potential donors because they weren't the perfect donor they were looking for. Months passed by with no donor they deemed would work. That was until 6 months later, on Saturday, January 3rd, 1998, when they found somebody who seemed like they'd be a perfect match. And this was a 40-year-old man named Matt Douglas. Matt was rushed to the hospital after suffering a ruptured cerebral aneurysm. This is an aneurysm in the brain that ruptured. They intubated him and they tried working on him, but with no luck, because it was just less than 48 hours after being intubated when Matt passed away. Matt was a healthy guy. This ruptured aneurysm was very sudden and unexpected for his family. So on one hand, it was very unfortunate that the family lost their loved one, but then on the other hand, this provided the chance for Tim to receive a procedure that could potentially change his life for the better. Looking through Matt's medical history, he had no coexisting illnesses, he'd never smoked before, and after doing some lab work, he tested negative for cytomegalovirus and Epstein-Barr virus. All that was left was to see if his blood would be compatible with Tim's. They completed human leukocyte antigen, or HLA testing, and it was in doing this when they determined that both Matt and Tim were a match. As soon as they deemed him a perfect fit for being a donor, the doctors all gathered together and they got straight to work. They removed the donor larynx, and at about 10 p.m., they placed it in ice and in something called University of Wisconsin, or UW solution. This is, quote, an organ preservation solution that significantly extends the viability of a donor organ. Ischemia is defined as a lack of blood supply to a part of the body. This lack of blood supply can cause damage to the tissue because of the lack of oxygen and nutrients that results from reduced blood supply. Based on a 1994 study that Dr. Strome and the team did on rats, they found that while using the UW solution and ice, they had an ischemic time interval of 20 hours before the larynx would reach the point of ischemia or cellular injury. So they knew that this was the window they were working with before they needed to get on with the procedure. They stored the larynx in this solution and ice for a few hours. When finally, after 10 hours passed, they were ready to get on with the transplant. In the early morning of Sunday, January 4th, 1998, Tim was given immunosuppressive medications in order to suppress his immune system in preparation for this procedure. When doing a transplant like this, one of the biggest risks is rejection of the donor organ from the recipient's immune system. Thus, suppressing his immune system was done to make sure his body didn't attack the new larynx. Finally, at 8 a.m. that Sunday morning, they started with the surgery, with Dr. Strome leading it. Tim's damaged larynx was still inside of his body, so they had to remove it. But before doing this, they wanted to make sure they connected the donor larynx's blood supply to Tim's so that it remained viable when stitching together the organ inside of Tim's body. First, the team carefully identified and marked the blood vessels and nerves around Tim's larynx so that they could be preserved and connected properly. They then removed some of the surrounding tissue from the donor's larynx, exposing the key areas that would be transplanted. After doing this, they established blood supply with the donor larynx by connecting the arteries and veins of the donors with Tim's. Finally, once that was all established, they began carefully removing Tim's damaged larynx larynx from his body, being very delicate to make sure they didn't disturb the blood supply that was just established. After these connections were made, it was within just 30 minutes after releasing the clamp when blood began to flow through the donor organ, meaning that finally, after 8 hours, the transplant was a success. At that point, the blood supply was fully connected. All it was a matter of now was actually sewing the structures together. This was quite a hard task to say the least, because Tim's neck structures had actually been damaged so badly. They not only transplanted the larynx, but they also transplanted the throat, aka pharynx, trachea, thyroid, and parathyroid glands in order to maintain the blood supply they needed. Over the next 3 hours, they went on to make tweaks and adjustments to make sure the donor's structures were securely connected. They performed a narrow field laryngectomy, removing part of Tim's larynx and then removing a portion of Tim's trachea just above the stoma. Not only was the donor's larynx much larger and differently shaped than Tim's, but as mentioned, Tim's throat was actually narrowed in a few areas. With this, they had concerns of the sutures being too tight and thus potentially a fistula or abnormal connection forming. This is something they really wanted to avoid because if a fistula did form from a tight suture line, this can cause leaks and lead to the area becoming infected, which is something he especially didn't want to happen when considering that Tim was immunosuppressed. So to combat this, they decided to widen his throat or pharynx by transplanting 75% of the donor's pharynx. The human body has about 16 to 20 tracheal rings, and they were going to be keeping a stoma in Tim's neck. So in order to do this, they used 5 of the donor's tracheal rings to reconnect Tim's trachea at the stoma, but just recreating the stoma just a bit higher up. With these additional changes, they connected the blood supply, they connected the nerves together, and finally, after a total of 12 and a half hours, they sewed the last suture together, officially finishing the transplantation. The procedure might have been done, Tim did survive it, and Dr. Strome and the team may have practiced several times on animals, but they've never done this on a human. All it was a matter of now was waiting to see if this surgery worked and if Tim would finally be able to speak again. The day after the surgery, they removed the tracheostomy tube and operative drains that Tim had in, and throughout that week, they gave him the necessary medications, mainly immunosuppressants, and even medications to make sure he didn't produce too much saliva. Initially after the surgery, Dr. Strome told Tim that for his recovery, he needed to not speak for 6 weeks. But after 2.5 days of remaining silent, on the 3rd day post-op, according to a New York Times article, Dr. Strome stated that he, quote, couldn't stand it any longer. And he headed inside Tim's room, put on some gloves to cover Tim's stoma, and he told him, quote, I want you to breathe out and say hello or something. Tim's head and neck were so swollen that he himself wasn't even sure if this would be possible. But he was like, you know what? I'm going to give it a shot. Finally, after this lengthy operation and 20 years of not speaking, Tim blurted out the words, hello and hi, Mom.
Okay, one more breath. Now the hi, Mom.
Dr. Strome described that his voice was very coarse and breathy because during that moment with him recovering, the sound he made was without the use of his vocal cords, but were rather the result of his voice box fluttering. In our body, we have 2 vocal cords, which are also known as vocal folds. The sound we produce is the result of our vocal folds snapping together, vibrating as the air from our lungs blows past them. These vibrations of our vocal folds then travel through our throat, nose, and mouth, which act as resonating cavities to modulate or adjust the sound. But coarse voice or not, it was a voice, something he hadn't had in 2 decades, and that was only a few days post-op, so there was definitely ample time for it to improve. Initially, after the transplant, when they touched his vocal folds and the area above it using a flexible laryngoscope, he suffered with a severe cough. But it eventually got to a point where he only had sensation whenever it was touched and no cough. For 3.5 months after the operation, Tim wasn't able to swallow, so they fed him through a gastrostomy or feeding tube. It was then around mid-April when he finally was able to swallow adequately and no longer required the feeding tube. They performed a barium swallow test, and there was no aspiration of solids or fluids, aka there were no foods or liquids that accidentally entered his lungs whenever he ate or drank. And Tim's sense of taste and smell also came back. Within just a month, as he regained his sensation and nerves grew together, he was back to being able to eat pretty much anything. As his swallowing had improved, his voice quality continued to improve. Just 3 weeks after the operation, Tim spoke to press at the Cleveland Clinic Foundation.
The possibilities are really unknown because being able to speak again is going to change my whole life. It's just amazing. It's incredible. I mean, just amazing.
They had Tim listened to by a trained listener, and as the months went on, Tim's vocal cords began moving to the correct anatomical position, and his voice quality continued to improve. They evaluated him on 6 measures of phonation, or sound production: pitch, jitter, intensity, maximal phonation time, respiratory volume, and airflow. Both of these subjective and objective measures of phonation gradually improved, with his voice actually becoming stable at normal or near normal levels 16 months after the transplant in May of 1999. During that month, the pitch of his voice changed, which increased its natural quality. And by 3 years following the transplant in January of 2001, the characteristics of his speech were all within the normal range. His voice sounded normal, and everything he needed to do communication-wise, verbally, he was able to do. His voice at that point was good as new, with the case report of him stating that he has a, quote, human-sounding voice with inflection, range, and qualities unique to him.
I'm the recipient, but without a donor, without a doctor, and without faith, it wouldn't have worked. And, here it is. And a lot of people said it wouldn't work. Well, it worked.
Tim was very pleased with the results, expressing how this change has immeasurably improved his quality of life, stating, quote, "It took a good 1.5 years until I didn't sound raspy, but any voice is better than no voice." And Dr. Strome was very pleased as well.
He has a totally normal speaking voice. Yeah, it is. It's amazing. The results are really beyond my wildest dreams.
Tim further described the struggles he faced being a person who didn't have a voice for so long.
I feel so much better being able to speak again. It's great. My outlook on life is, I keep going and going and going. I don't feel down anymore. It's one of the greatest things that has ever happened to me.
Very soon after the transplant, actually just a few months after, in that very summer of 1998, he was able to sing Old MacDonald Had a Farm. And very soon after, in 1999, he was already able to sing hymns in church. Getting to high notes at the time was difficult, but nonetheless, he was still able to sing.
Great, you're doing just perfectly.
As you can notice, run the pitch way up. In the land of the free and the home of the brave.
A major question Tim would be asked was if he sounded like the donor, Matt Douglas. The donor was actually a singer whose voice was recorded on tape. But long story short, the answer was no. Tim didn't sound like him.
I don't sound like the donor because we have audio tapes of him. And he was a very large man, and he had a real low voice. And I have 2 brothers and 4 sisters. And we think, if anything, I sound like my dad.
Our voice boxes come in different shapes and sizes. How we sound depends on our articulators, including our lips, cheek, tongue, and palate. Dr. Strome explained that how we sound relies on different factors, including the shape of our mouth, and he even said that the amount of space we have in our head for the sound to resonate. Further stating that in general, it's actually very normal for us to sound much like one of our parents. kind of like the same way our accent depends heavily on our regional or geographical location. Thus, if someone were to get a larynx transplant, they wouldn't sound like the donor. Now, as for the stoma, you can see that Tim still had it. At first, they kept it open, of course, to have access to his new larynx in case of any complications. But they initially planned to close the stoma 1 year after having completed a minimally invasive procedure called a laser cordotomy to treat paralysis of his left vocal cord. If they closed this up, he would still have a fully usable airway and it wouldn't have affected voice quality. But still, the stoma was fine. During their 34-month follow-up, so almost 3 years, it hadn't granulated or gotten rough textured. By 40 months, so almost 3.5 years, it was self-sustaining, and at that point, they decided to just leave it and think about it some more. Something they tried to do instead, however, was implement a self-closing external valve at the stoma. But they were unsuccessful in doing this. Ultimately, in the end, they decided to keep the stoma. So with this, in order to speak, Tim would have to cover the stoma to force air through the transplanted larynx. Although everything was looking good, he was stable, his counts were great, this didn't stop the fact that during recovery, he did suffer a few different health issues. After being discharged from the hospital, for those first 6 months, Tim had a monthly follow-up, but after that, follow-ups were made every 3 months to do endoscopic imaging, and he also had a yearly biopsy to inspect the graft. Tim was provided with antibacterial, antifungal, and antiviral medication to be continually used both during and after the transplant. 3 weeks post-op, he suffered a mild case of oropharyngeal thrush, but after treating it with medications, it subsided. But then at 16 weeks, 18 weeks, and 15 months post-op, he suffered 3 episodes of tracheobronchitis, which is inflammation of the trachea and or bronchi in the lungs, which in his case was the result of an infection. During the first episode he had at 16 weeks post-op, the case report states that Tim inexplicably stopped taking the antibiotic that he was prescribed to routinely use after the transplantation, commonly sold under the trade name Bactrim, Cotrim, and Ceptra. This is a medication used to treat and prevent various bacterial infections, including pneumonia. But after stopping taking it, with being on immunosuppressive medications, it was during this episode when he developed pneumocystis carinii pneumonia. They made sure to keep Tim's responses monitored by assessing his plasma drug concentrations and conducting biopsies of the mucous membrane of the partially transplanted trachea. Fortunately, throughout that first year, none of these biopsies showed signs of rejection, and recovery was going relatively fine. However, it was just 15 months post-op when this did, in fact, take a change. Sometime in April of 1999, Tim noticed that something was a bit off about his voice. The quality of his voice just wasn't as good as usual. He took note of this and said, you know what, I'm just going to wait it out and see if it'll get better. But after several days went by, it was not getting better. In fact, the quality of his voice just kept on getting worse. Each day, it continued to decline until one day he just fully became aphonic and could not speak. It was after this when Tim contacted the doctors to get checked out. After heading to the Cleveland clinic and seeing the doctors, they did some assessments on him. Tim's larynx was swollen and filled with excessive amounts of fluid. And after fully evaluating him, they told him that he was experiencing an episode of rejection. They quickly got to treating this by giving him high doses of prednisone, an immunosuppressive corticosteroid, in order to combat the rejection. And fortunately, within 3 days after this, Tim's larynx function returned back to normal and he was able to speak again. They then went on to make some changes with his medications, and after that, he had no more rejection episodes for the time being. Before the transplantation, Tim was unemployed, but afterward, he found work as a motivational speaker. He went on to be interviewed on radio, on TV. He spoke at medical conferences, he spoke to nurses, and he spoke to laryngectomy patients, sharing his story, describing how the surgery has helped him, and expressing how it could potentially help others. others. On Monday, June 8, 2009, about 11 and a half years after the procedure, the Plain Dealer Cleveland shared an article providing an update on how Tim was doing. Tim, who was 51 years old at the time, told Mary Ann Whitley with the Plain Dealer, quote, "My main goal out of all of this was to be able to help people." He mentioned something similar in the New York Times article from 1999, acknowledging that the people who've too lost their larynx were, quote, "looking at me because they're so frustrated with life and want a transplant right now." Also in the 2009 article, Dr. Strome described the help they'd gotten from Tim in doing more research for this. He described Tim stating, quote, "As far as I'm concerned, he's been a rolling laboratory. There's so much he's enabled us to learn." With Tim being the first patient to receive this, they were still trying to figure out things like how much they could lower the dose of immunosuppressant drugs, especially as that is something Dr. Strome did want to do to decrease Tim's risk of infection. Having Tim around allowed them to continue to learn about what would work and what would not. Regarding the notion of him kind of being like a human guinea pig, Tim stated, quote, "The only difference between me and the rat is I can talk and the rat can't tell you how it feels." By that point, in 2009, Tim was the only person in the US who had gotten a larynx transplant. Besides him, there were just a couple others who'd gotten one in Colombia. Dr. Strome described, quote, "We now know what no one knew then, that we can anticipate that people will talk with a nearly normal voice, that they'll be able to swallow. We know that the thyroid will function. That's all because of him. And the reality is, with just a little more research, we'll be able to transplant patients who have cancer of the voice box, and that's the biggest number of patients out there." A transplant surgeon named Anthony Monaco from Harvard Medical School had his larynx removed after a cancer diagnosis in 1994. But in a 2001 article, when he was about 69 years old, he described he never thought something like this would be possible anytime soon, stating, quote, "Strome and colleagues have proved my prediction to be pleasantly incorrect. If I were 40 years old, I would probably consider undergoing the operation myself." Dr. Strome said that it would be a goal for them to perform this on a cancer patient next. But according to a 2024 study written by him and other related physicians, quote, "The place of laryngeal transplantation in head and neck oncology has been questioned due to the need for immunosuppression and therefore possible tumor recurrence." Because of this, he and other clinicians have been wary on performing the procedure on people with laryngeal cancer. That was, however, until February 29, 2024, when for the first time, doctors, led by Dr. David Lott at the Mayo Clinic, implanted a larynx into a laryngeal cancer patient named Marty Kedian. Video on that will be coming soon because this was a huge feat. Dr. Strome said that as of the time in May of 1999, he had 5 patients who wanted a laryngeal transplant. But one of the major problems with this procedure was that it was and still is extremely expensive. At the time, it cost an estimated $200,000 US, which is equivalent to $390,000 today. These potential candidates who wanted it at the time couldn't afford this steep price, and insurance companies weren't going to be paying for the experimental procedure. Today, larynx transplants are about the same price, ranging between $200,000 to $400,000, including surgery, preoperative assessments, and aftercare. Still, these are most often not covered by insurance. The price of this operation has been one of the points brought up on the ethical concerns of laryngeal transplantation. Losing laryngeal function is something that has serious effects on one's quality of life, especially as the larynx is responsible for 3 very critical aspects of social and functional abilities of humans: communication, respiration and breathing, and swallowing. There have been various solutions developed and used for many years to help those without a larynx or those with a damaged one, including Electrolarynx, development of tracheoesophageal speech, laryngeal pacemakers, and various designs of stoma. But at the time, there is no comprehensive, holistic, and therapeutic approach that addresses these three main functions of the larynx when treating laryngeal issues. Laryngeal transplantations come with many complex challenges, as does any vascularized transplant of different organs, whether that be finding a donor, risk of rejection, or infections. But particularly with a transplant like this, where it's considered a non-essential transplant, there's ethical concerns regarding the risks associated with keeping somebody on lifelong immunosuppression for a problem that's technically non-life-threatening. While it technically may not be life-threatening to lose these functions in the sense that somebody could physically stay alive without a larynx, this doesn't stop the fact that losing a larynx has tremendous effect on both psychosocial and physical morbidity. Most of the time, for people who've suffered laryngeal trauma or who have gotten a laryngectomy for non-oncologic reasons, can manage their condition through conventional swallowing therapy to help improve one's swallowing, through voice rehabilitation techniques, and or even through the use of long-term stoma. And according to the report, it is possible for this to happen with a reasonable quality of life. That being said, there is a small percentage of people in which these treatment options are either not possible or unacceptable for them. A 2008 study which surveyed 372 laryngectomies found that 75% of them stated that they would, quote, find laryngeal transplant acceptable if it did not result in significant morbidity. But get this, when they were asked if they would still do the transplant, even if it hypothetically meant they still had to keep their stoma, the amount of people who found it acceptable dropped down to 58.9%. Which showed that for many, having the stoma was truthfully one of the things that affected them the most, which is very reasonable considering the many problems one might experience with a stoma, whether it be leakage, bleeding, hernia, or sore skin. Throughout the study, it was emphasized by most participants that they would actually rather lose their stoma than regain their normal voice. And approximately 50% of participants were willing to accept a transplant even if it didn't end up resulting in a normal voice afterwards. Like many other composite allotransplantations, larynx transplants are done with the intent to improve the quality rather than the length of life. Because while they may not be physically dead, according to Dr. Katrina Bramstead, those without a larynx who have a stoma might be suffering through social death, which, if you remember, Tim himself had even described. Dr. Strome described the debates over the ethics of non-essential transplants as valid and important, but he further stated, quote, what about the folks who don't want to live their life without a voice? Shouldn't they have the opportunity to have it done if they understand the risk? On July 6, 2024, a report was published by Dr. Estefania Candelo et al. Titled The Global Experience of Laryngeal Transplantation, series of 11 patients in 3 continents. This was a case series created by several doctors who'd been involved with larynx transplants from around the world, including Dr. Strome. In this report, the doctors looked at 11 patients across 3 continents who've received total laryngeal transplants from between January 1998 to September 2022. 2 in the US, 5 in Colombia, and 4 in Poland. The second person in the US who had gotten a transplant was a 52-year-old woman named Brenda Jensen, who'd received the procedure on Wednesday, October 13, 2010, directed by Dr. Gregory Farwell at University of California, Davis Medical Center in Sacramento. The Colombia transplants actually first started in 2002, where they performed 13 laryngeal tracheal transplantations. The first one being led by Dr. Luis Fernando Tintinago at the University of Antioquia and San Vicente de Paul University Hospital in Medellin, Colombia. The reason the rest are not included in this report was due to them not being total laryngeal transplantations. To all the doctors' knowledge, the 11 cases were all of the known reported and unreported cases of revascularized total laryngeal transplantation that occurred at 4 different centers across the 3 continents. The causes of laryngeal failure in these cases were trauma, including infection, cancer treatment, or unintentionally from medical treatment. 4 patients had infections after therapeutic radiation for cancer. 4 patients suffered severe laryngeal and pharyngeal trauma. 2 patients swallowed corrosives and had chemical injury. And 1 patient developed severe laryngeal dysfunction after traumatic endotracheal intubation. 10 patients received previous surgery, and preoperatively, 9 patients were aphonic, while 2 had poor voice quality. In each of the cases, all options before transplantation were looked at, but ultimately, there were no ideal conventional solutions. These patients did qualify for the transplants, and they were given full informed consent. For the procedure, the way the different doctors connected the vasculature had some similarities, but they also varied depending on the institution and the preferences of the medical teams. All patients received immunosuppression, and 1 was already on immunosuppressants from a prior kidney transplant. But the specific medication used varied amongst the different institutions. Because there wasn't standard criteria, the teams just had to evaluate rejection subjectively by seeing if any new symptoms of difficulty swallowing, breathing, or speaking developed, and by doing endoscopic imaging to see if there's inflammation or edema. The average length of stay in the hospital post-op was 59 days, with the range being between 27 and 90 days, and complications experienced by patients were described as relatively frequent. 3 patients experienced complications within 24 hours of doing the transplant. These were referred to as early complications. In the first 30 days, 6 patients experienced complications, including things like massive bleeding, pneumonia, sepsis, and stenosis, or narrowing of the blood vessels. 8 patients suffered complications after 30 days post-op, which were referred to as late complications, with the main one being stenosis. All in all, out of the 11 patients, 3 had passed away from complications. The first one being pulmonary embolism on day 1 post-op, and 2 being sepsis at 6 and 18 months respectively. Regardless of these 3 patients passing away, they all had viable grafts at the time of their death, meaning their larynx transplant was fully functional and well. It was rather the complications from the procedure and treatment that ended up resulting in them passing away. Most of these patients were able to get to an appropriate level of laryngeal function pretty early on. The first competent swallow was observed at a mean of 5 months, with the range being between 2 to 7 months, and most achieved regular oral intake at approximately 8 months, with the range being between 2 and 16 months. There were still limitations, however, present in most patients, with only 2 being able to manage a full oral diet at 1 year post-op, and this did rise to 4 patients by 2 years post-op. Regarding voice quality, at 1 month post-op, 6 of the 9 survivors had usable voices, and at 6 months, 7 of the 8 had usable voices, which were described as satisfactory at 1 and 2 years. However, they found that not all aspects could be close to perfect all at the same time. They stated, quote, "No patients convincingly demonstrated complete restoration of voice, swallowing, and oral nasal breathing, although 3 patients had significant performance in all 3 functions." They described how with this procedure, improving all of these aspects at once was not something that could be easily achieved. Those with paralysis of both their vocal cords were left with essentially 3 options to have: an open position to improve breathing but having a weakened voice and exposure to aspiration, a closed position to improve voice and reduce aspiration but having an impaired airway, or some intermediate compromise. At the time the report was written, so about 2022 to 2024, only 2 of the patients still had a stoma. And the report described that for patients who did get their stoma removed, they sometimes needed to perform procedures to further open up their airway in order to prioritize breathing over better voice and swallowing. The report mentions that 3 patients were tracheostomy dependent, meaning they kept their stoma. And it further described that these 3 patients did in fact have voices voices that were considered good or excellent, likely due to the fact that their vocal cords were the closest together, since they didn't have to widen their airway to breathe, as they could just continue to breathe through their stoma. But though there were positives, there were also negatives for recipients of this procedure. Regarding rejection, 3 patients experienced early rejection, while 4 patients had an average of 1.6 episodes of presumed chronic rejection during the study period. And even in these cases, the mean time the first event occurred amongst the patients was 66 months, so 5.5 years. 4 patients had structural changes in the transplanted larynx, possibly related to the chronic rejection. This rejection resulted in 1 patient undergoing partial graft excision, meaning surgical removal of the affected part of the graft at 18 months. But this also resulted in 1 patient undergoing total graft excision 14 years post-op. And this very patient was Tim Heidler himself. Because in January of 2012, Tim removed his transplanted larynx due to chronic rejection. Sometime in 2010, during Tim's 12th year post-op, he began noticing some discomfort in his throat area, and as he experienced before, his voice quality began worsening. He ended up getting checked out by his doctors, and they found that he had developed a mucosal lesion in his throat area. They tried treating him with IV antibiotics, but it didn't respond well to this. So they went on to not only do a biopsy, but they did a debridement of the area. And with this, they found, quote, ulceration, granulation tissue, and acute inflammatory cells with bacterial overgrowth. Shortly after, they gave him an extended course of IV antibiotics. And although this did in fact improve the ulcerative area, Tim's voice quality and discomfort still progressively got worse. Just 2 years later, in 2012, during the 14th year post-op, his larynx function decreased so much, by that point, he was contemplating getting his larynx removed in a procedure called explantation. His throat hurt so much, the pain radiated to his ears, and his voice quality deteriorated to becoming, quote, breathy with poor pitch control. With the immunosuppressive medications, the goal ultimately is to lower the dosage needed over time. And Tim did in fact get to the minimal level of immunosuppression that worked for him. However, during this time when he was dealing with these symptoms, when they increased the medication levels, both his pain and voice quality improved, and the edema he had in his vocal folds also decreased. But as the vocal fold edema decreased, the amount of liquid aspiration, aka liquid accidentally entering into the lungs whenever he drank fluids, increased. They tried treating him with an injection of a voice gel implant called Radius Voice. His vocal folds were stiff, and they were hoping this injection would help get them more towards the middle in a better position. But unfortunately, this was unable to help with that. While Tim's condition wasn't life-threatening, it did become increasingly bothersome. His voice quality really wasn't that good, and he had chronic discomfort. It was because of this, dealing with these symptoms for so long, he decided it would be best to get the larynx removed, which they eventually did. After the procedure, Tim received a tracheoesophageal puncture, or TEP voice prosthesis, a device used to redirect exhaled air from one's lungs to go through their esophagus and expel through their mouth in order to create a voice, described as, quote, the most common way to restore speech after a laryngectomy. They provided him with routine TEP counseling to help with his transition in communication. After the procedure, they completely weaned Tim off the immunosuppressive medications, and he fortunately got to a point where he was fluid with the use of his TEP voice. After reflecting on the overall experience of Tim from the transplant to the removal, the report states, quote, The patient states that he had no regrets in deciding to undergo the transplant and was thankful for the opportunity it created for the scientific community to learn from the experience. Reflecting on the advantages the transplant had afforded him, including improved swallowing, taste, and smell, he prioritized the expressive aspects of being able to communicate emotion through voice as the most important quality of life improvement he had experienced through the transplant. And he would accept the opportunity to undergo a second larynx transplant if afforded the opportunity. They also stated that the experience of Tim is, quote, the longest surviving maiden transplanted organ system when immunosuppression was applied. Something that is also of very important note from the report is that they mentioned that they found, quote, an area of squamous cell carcinoma. Now, they mentioned that the cancer was minute, and after finding it, he was subsequently taken back into the operating room to do a resection procedure to remove the cancerous tissue. From this, all the cancerous tissue was removed, and they didn't need to do any additional therapy to treat it. The report stated that as of 12 months following the larynx removal, he remained cancer-free. Likewise, in the 2024 report, he did as well. And from what I've seen on updated pictures from this year, 2025, he looks to be doing fine. But I haven't been able to successfully reach him, and there are no other publicly available updates other than the 2024 report that talks about his case. Overall, they summed this all up by saying, quote, several patients are free from tracheostomy, speaking, and with oral nutrition, although their voices tend to be somewhat breathy and there is residual unquantified risk of aspiration. They emphasized the importance of documenting and publishing the outcomes of laryngeal transplant cases so they can figure out how to progress in the future. While it's difficult from the report alone to determine if this method is a better one, they expressed that what the report can do is allow potential patients of the procedure to see the outcomes to help them make a more informed decision. Regarding the 3 of the 11 patients who passed away, they cited this as a potential cause of concern, but they brought up the fact that this is a small sample group and they're still learning, so as more outcomes and cases can be assessed, it should hopefully help in reducing the risks for what they described as preventable causes of mortality. On January 7th, 2025, an article was published on ENT and Audiology News by Dr. Martin Birchall, a surgeon who took part in the larynx transplantation of Brenda Jensen. To his knowledge, there are now 16 documented laryngeal transplantations in the world, with the recent one from the US, in addition to 1 each in China and France, and 2 more in Poland. Out of the 11-patient cohort from the report, since 2022, 1 more patient has had their larynx removed after 6 years due to chronic rejection, and 1 more has passed away from abdominal problems. Going forward, the main things they're hoping to look at are standardized and validated ways to measure the outcomes of quality of life, psychological well-being, social function, surgical and rehabilitation protocols, and rejection criteria of recipients. Despite the several anecdotal reports of people being satisfied and having high function, they stated, quote, no detailed quality of life and psychological studies have been performed on this cohort to date, but this is an important area for future exploration. Having formal measurements of these aspects would be very important in helping figure out what might be preferred for a patient regarding things like vocal cord position, for example, because based on the psychosocial outcomes, that might help figure out if one would prefer to prioritize either breathing, swallowing, or voice. And they suggest that there could be a possibility that adding additional devices such as laryngeal pacemakers and or robotic implants in addition for the recipient might be able to help in providing them a higher quality of life outcome. They also further suggested having an international registry for rejection criteria in order to have a consensus on the measures of rejection, as composite organ allografts do. After assessing recipients who previously had cancer, they found that none of them had recurrences as of the time of writing in 2022. 2, and the patients were reported as being 10, 6, and 24 years cancer-free, respectively, which suggested this procedure could be possible in those with advanced head and neck cancer, which we discussed was shown in Marty Kedian. Overall, laryngeal transplantation is demanding for everyone involved, the carefully selected recipients, surgical teams, even the donor families. While it comes with many ethical and technical questions, the report describes it is, quote, technically feasible with good graft survival rates and complications that are mostly manageable. Nonetheless, this is a very major procedure with significant mortality and morbidity and should still be regarded as experimental or compassionate use only for the time being. Dr. Strome went on to be recognized for the contributions he's made in medicine, receiving various awards and accolades. He continued developing new surgical procedures, he continued lecturing, he served on several scientific advisory boards, and he continued authoring and contributing to more than 200 scientific articles and book chapters. They showed that laryngeal transplantation is feasible, with Dr. Douglas Hicks stating from the 2009 article, quote, this was a major life-changing event for him. You take a very shy, quiet guy like Tim, who was living in the quiet woods of our country, and he desires to be a firefighter and help others, and this accident intervenes and changes his life. He steps forward as a courageous pioneer, and because of the novelty of it and the success of it, he becomes an immediate celebrity, and that requires him to be on stage, and he has to serve that celebrity function using the very voice he desired and was granted. The voice is telling the whole story. That is even more amazing than the story that broke 11 years ago. It is unfortunate that Tim had to have the transplanted larynx removed due to chronic rejection. I hope he was able to enjoy the 14 years he did have with his voice back again, and it's nice to know that he does have a new voice with the TEP. It was very warming to read about how much having his voice back impacted his life, and this is really just the start. He was the first person to get this done, and as of right now, on paper, there's only been 11 total recipients, so hopefully as time goes on, the procedure can continue to improve as other transplant procedures continue to improve throughout the years, and it should be interesting to see where these transplants can go. Tim, before getting the surgery, left us with some very true words.
I'm a fighter. That's what I am.
But yes, that is it for this video. What are your thoughts on this case? Do you think it is ethical to do larynx transplants? Do you think they should stop doing them, period? Please comment your thoughts below, and don't forget to subscribe so you don't miss any other videos on medical cases, crime, and mysteries. Bye now.
So far, so good. Everything's doing good.